صراحة اليوم عندنا واحدة من الاكتيفيتيز اللي هي مطلوبة من عندنا عالميا على موضوع البينويك اللي راح يصادف من يوم 5 إلى يوم 11 شهر الرابع. فراح نتحدث بها عن الفينوس ديزيز. هي الاكتيفيتي كلها عن الفينوس ديزيز والليمفاتيك ديزيز. احنا اختارنا موضوع مختصر ان شاء الله راح نغطي به اليوم الفاريكوز فين وشوية نتكلم عن الديب فينس ثرومبوسيس. What is the VENOUS? VENOUS really it is not for profit, public and health professional venous lymphatic awareness global project. Rational from April 5th to 11th, and this is including the Health Week. During this week, the WHO will celebrate on the 7th of April the World Health Day, and they use this date from 5 to 11 for venous lymphatic awareness to present some scientific activities to increase the awareness about venous diseases.
Venous?
No.
Venous diseases?
No. So first we will talk about the anatomy of the varicose vein. Superficial vein, the great saphenous vein originated from the dorsal venous arch of the foot. After passing anterior to the medial malleolus, it runs up to the medial side of the leg. At the level, it runs over the posterior border of the medial epicondyle of the femur bone. Here. The great saphenous vein then courses medially to lie on the anterior surface of the thigh before entering the saphenous opening. It joins with the femoral vein in the region of the femoral triangle at the saphenofemoral junction. While the small saphenous vein it starts on the lateral aspect just posterior to the lateral malleolus and runs upward to meet the popliteal vein. In general, the saphenous vein can be defined as a dilated, elongated, tortuous, and palpable superficial veins as a result of venous hypertension. It usually occurs due to a permanent loss of valvular mechanisms and result in venous hypertension. In general, there is what is called CR classification to classify the severity of varicose veins or chronic venous disease. It starts from 0 to 6 up to 6, and CR it is a short term for clinical, etiological, anatomical, and pathological causes of the varicose veins. In general, we are more interested in clinical terms. So, in class 0, there is no visual or palpable signs of chronic venous disease, completely normal. In class 1, the patient has only telangiectasia and or reticular veins. In class 2, there is varicose veins. Class 3, when there is edema started, when the patient has edema, whatever he has, reticular veins, telangiectasia, or varicose veins, it will be classified as class 3. At class 4, usually there is skin changes in form of hyperpigmentation and sclerosis. In class 5, if the patient has already healed ulcer, so this is class 5. If the patient with active ulcer, venous ulcer, it will be classified as class 6. A lot of people ask what are the causes of varicose veins. In general, varicose veins, there are certain risk factors that predispose to it. Mainly there is genetic predisposition, so sometimes we can find a lot of cases runs in families, and in some patients who are on long-term use of hormonal drugs, for example, oral contraceptive pills, some steroids can predispose to varicosity. Being a female is another risk factor. Prolonged sitting or prolonged standing is another risk factors for varicose veins. Age over 50, due to generalized aging process and laxity of the skin and all muscles, it can be also a risk factor of varicose vein. Pregnancy, also due to increased intra-abdominal pressure and a prolonged period of compression of the iliac veins, it also causes varicosity. Obesity, the same explanation for pregnancy and smoking. Here we can see the healthy leg, and here we'll see the varicosity. We'll talk later on. Complications. As we know, any disease has its own complications. Varicosity, really, it has a lot of complications, including bleeding, and that is due to dilated veins, very weak wall. It can cause these vessels can be easily bleed when can be touched by trauma or even spontaneously. Thrombophlebitis due to stasis and abnormal blood circulation in these veins, so there is a risk of infection and clot formation, and that is the pathophysiology of thrombophlebitis. Venous hypertension leading to venous ulcers. This is the end result and welcome complications of varicose vein, venous ulcer. Calcification, it can occur after thrombophlebitis. And Talipes equinovarus deformity of the foot, eczematous, dermatitis, and hyperpigmentation or pigmentation in the area involved, psoriasis of the subcutaneous tissue in the surface of the tibia. And sometimes the venous ulcer can be complicated if it is untreated and stay for a long time by malignant changes, what is called Margolin's or Margolin's ulcer. Here are some pictures that explain it is clear some forms of varicosity. It can start as either spider veins or telangiectasia. Here the small saphenous vein, or they call it now short saphenous vein, varicose veins. And here the classical pictures of pregnancy varicosity. The normal blood flow usually in the vein start distally up going to the heart. So in the varicosity there is a reverse direction of flow due to a diseased valve. Normal valve, usually there is a closure of the valve when the after the pump action start of the calf muscles and the skin, when the blood rise up, and by the way, the blood will be prevented from going down by this valve mechanism. While in varicosity, that usually occurs after all these risk factors that I mentioned. Sometimes it occurs due to a DVT, deep venous thrombosis, that eventually causes disruption of the valve mechanism and failure of coping of the two valve edges to be closed. Really, there is two theories behind the pathophysiology of varicose veins. Some people goes with descending theory and will explain it, and some goes with ascending theories. The descending theories, as we think previously, that the main cause of varicose veins is failure or reflux at the saphenofemoral junction, and that failure in the main valve in the saphenofemoral junction will cause the blood to go down, and with time there is more blood accumulated in these veins, causing them to be more dilated and more lax. So this is the original theory. Some people and researchers now goes with ascending theory. The primary problem starts distally with these telangiectasia and reticular veins, causing more blood to be accumulated in these veins, and this will, with time, will cause more blood to be accumulated in these veins that make the valve tract from distally, not from proximal. Distally, there is the tracking, the weight of blood, and consequent tortuosity that happened in the wall with the thinning of the wall will cause failure, later on failure in the major valves. The skin changes. Obviously, we said in the classification of SIAP classification, it will start skin pigmentation after the stage of 4 or class 4. And this is mainly due to venous hypertension. In venous hypertension, there will be hemosiderin accumulation, pigment outside, extravasation of the blood outside these abnormal vessels will contribute in these skin changes. And these changes will include changes in the color, mostly goes with hyperpigmentation, and the thickness. The skin at this area will be very thin and liable for easy trauma, and almost always it is itchy and easily injured. And here we can see the venous ulcer site. Mostly it occurs on the medial aspect, but can be happened higher or on the other side, but this is mainly the classical site for venous ulcer in comparison or that accompany the varicose vein of great saphenous vein. You know that most powerful and unique diagnostic tool for varicose vein, we are using the Doppler ultrasound. The Doppler ultrasound, and we can see if it is clear the valve anatomy with high frequency linear probe. We can even see the anatomy of the valve, if it is functioning or not. So we can have a dynamic picture of the valve while it is functioning. The other important things that we are looking for in varicose vein is the presence or absence of reflux, which means that is the blood going to stop when the valve is closed, or it will be continue descending down after the valve as if it is closed. So competent or incompetent valves, it can be defined in a matter of time. If, for example, the great saphenous vein at the entrance of the femoral vein have a reflux time 0.5 seconds and less, it can be called competent. This is normal. And by the way, this test should be performed on the patient while he is standing. Most of our sonographers do this test while the patient is on supine position. That may give us a false result. But if it is done properly, this is the proper time to say that this valve is competent. If it is more than 0.5 seconds, it will be called incompetent. And for the perforators, if it is more than 0.3 seconds, so it is also called incompetent. While the deep system, the deep valves, if it is more than 1 second, so this we regard it as a reflex of the deep veins. What is the importance of reflex? Why we have to classify patient accordingly to be competent or incompetent? Mostly, if the valve is incompetent, this is the cause of the disease, and we have to prepare the patient to either stripping or ablation of this diseased valve and vein to prevent the subsequently of the varicose complications. So this figure is so important. Now this is with the pulse wave, we can see it is more than 6.6 seconds. So obviously this is an incompetent valve. Compressibility. This is another important that we are look for in any patient with varicose veins, because sometimes varicose veins is a secondary due to thrombosis in the deep system, or sometimes it happens that the patient had previously a deep venous disease and already recanalized, but the varicose vein present. So the management will be different if the patient with acute DVT or chronic DVT. So at any time we look for a compressibility of the vein. Here we can see the dilated vein when we push on the probe, so we can, it is almost absent the vein. Here the artery, it will be not compressible easily. Thrombus formation also can be seen, and we can, from the Doppler study, we can say that this is an acute thrombus or it is a chronic thrombus, and that is depends on the degree of whiteness or trabeculation that happened inside. So this is with compression, there is something inside the vein that cannot be compressed totally, and there is some trabeculation inside the vein. Here, collecting the reflex picture that we talk about, and here is the important sign if we are looking for the saphenous vein in the thigh region. It is almost the shape of Egyptian eye, and this picture is important to identify the exact diameter of the saphenous vein, because all of our management will depend on the size, because even for laser or radio frequency, we have a limited size to be done. If it is more than 2 centimeters, even the laser or radio frequency will have no role in this patient. So we will go to the old school and do stripping. So this is important. This is the classical surgery that we previously did on varicose vein, what is called stripping and ligation. But nowadays, why we stop to use this type of surgery? Really, maybe 5 to 10% only of patients will be candidate or will be benefit from surgery now, because of the availability of other mode of treatment that is make better results, and even the patient mobilized early. So stripping, there is some withdrawal, and most of our patients and all surgeons face this problem, that after surgery the patient comes after 6 months, 1 year, maximum 2 years with a recurrence. It is not a fault of a surgeon. It is about the pathophysiology and the nature of the disease. Varicosity, it is a matter of revascularization. Whatever you have an incision, there will be revascularization. Even if the incision, it is not for varicose vein. Sometimes in inguinal surgeries, for example, for a lymph node or whatever mass like lymphoma, after that the patient will have varicosity, which in any form, regarding either spider or a big varicose vein. So nowadays we need minimal intervention, so we will cause less trauma and better results. So that's why we are now less and less goes with less minimally invasive treatment for varicose veins. Microphlebectomy. This type of surgery, we use it mainly if the patient have a very superficial veins below the knee. It can be done under local tonicent anesthesia. It is mainly below knee surgery, and the risk for nerve injury is much minimal in comparison with the classical stripping. And also it is cost effective. This is the principle of the microphlebectomy using the Varadi hook technique. Usually we make a very small, tiny incision, about 3 millimeters in diameter, using the needle. Even without a knife can be done. And after that, we will make a tonicent anesthesia around the vein, so will give us a space and make the vein more away from important structures like nerve and skin. And after that, we will pass the hook, trying to get the vein, the dilated vein, through this small opening and do the procedure as if it is a classical stripping and ligation, but it will be a micro surgery. A lot of talk nowadays about laser and its role in the management of varicose vein. So laser endovascular laser ablation, it goes in different modalities. The old one with 980 nanometer, the nowadays 1470 nanometer. And the fibers also is different. They are using different fibers. The bare fibers, it is used with the 980 nanometer lasers, while the radial fibers used with 1470 nanometer. Also, there are subdivisions of radial fibers nowadays. It comes with 1 ring or 2 ring. And also this procedure can be done under local tomosynth anesthesia, and some center they use even spinal, regional or general anesthesia to perform the procedure. Radio frequency ablation, really this is now they are fighting between laser and the radio frequency ablation in a matter of cost and result. A lot of research nowadays talking about on each of them. Each company try to say that this product is best and that product is bad, but in comparison to be in the safe side, we are talking about radio frequency. The main advantages of radio frequency ablation is that the temperature that this device yield is much less than laser. So in the bare fiber in the previous slide, if you are talking about the bare fibers are 980 nanometer, the temperature might reach even 800 or 900 degrees centigrade. So we are using a tomosynth saline that should be cold, and still there is a risk of hyperpigmentation and should be used for only deep veins. I mean deep veins that is superficial veins but not so superficial, to avoid hyperpigmentation. Nowadays, the temperature of the 1470 nanometer goes down, may reach 120, 150. So that minimizes the risk of this hyperpigmentation. Radio frequency, it is using two types of devices or catheters, one with 7 centimeter the active part and one with 3 centimeter the active part. This one we use for great saphenous vein and the small one we use for short saphenous veins. As a technique, there is no difference between radio frequency and laser in the technique. As a result, I told you there is different research and each one try to do some bias about the study, but to me it is the same. Regarding the cost, laser is cheaper now because of the product of radio frequency. The reusable or not reusable, disposable product is so costly. This is the tomosynth we talk about, tomosynth anesthesia device. This is the device that usually used in microphlebectomy, in laser or radio frequency, because all these techniques, I mean the laser and radio frequency, they regard it as heat or thermal types of ablation, while there is another method which called non-thermal. So usually the tomosynth anesthesia device using a solution which is a mix of normal saline, adrenaline, usually we use it cold saline, adrenaline, sodium bicarb and xylocaine. And the advantage of that is to make the vein more compressible and to create a temperature lower than, cold environment, that when we apply the temperature by using the laser or radio frequency, we will have less damage to the nerve and tissues.
intravenous
This is put around the vein. After
يعني انت مخليه يعني نفس الفين اللي راح تشتغل عليه يعني during
the procedure we are using first to introduce the catheter under the guide wire.
الكاثيتر بالفين خلاص.
Now the catheter in the vein. After that, using the ultrasound machine, we inject around 200 to 500 ml of this anesthesia around the vein, along the vein.
يعني مو
not inside the vein.
يعني local injection by syringe عادية يعني.
Yes, this device, this is a saline with a tomosynth anesthesia and there is a foot switch. And this device, this catheter or this giving set, it is a special around 4 meters in length. And at the end there is a needle. This needle will be used to introduce the anesthesia around the vein. It will take no more than 5 minutes. We can give this is the rate from 50 to 200 ml per minute.
هذا السابي نصبين اللي انت تريد تسوي له كليته يعني راح تخلي الطرفه من فوق ولا من جوا ولا
along the vein.
الفين
Along the vein.
تحركها لو هي الحاله تروح.
Dr. Saleh, this is the great saphenous vein that we want to do ablation by laser or radio frequency, whatever the procedure. After we are inserting the catheter, so the catheter now inside the vein. Okay? This device is used to put the anesthetic, because it can, as I said, it can be done under local anesthesia. So total anesthesia, and that's it, the patient is awake. So by using this technique with foot switch, we can give between 50 to 200 ml per minute. So usually we go with 50, for example, per minute, and just do insertion of the needle with under ultrasound light, of course, and try to put the anesthesia around the vein. This amount of the fluid will compress the vein, because already the vein inside fascia, as I show in the slide. So this will cause compression. And at the same time, while we are performing the laser or radio frequency ablation, we perform another compression using the probe itself. And so we can monitor both the site of the catheter, the burning process that happened due to laser or radio frequency, and to make sure that, for example, we see the bubbles inside the vein while we are performing the procedure. The same device that used in liposuction, the same device. There's some talk about the steam varicose vein ablation. If it is clear, there is a catheter and there is some steam from here. This procedure is safe, cheaper, using just distal water, and but this is not within the guidelines. In European Venous Association, they are not regard as steam ablation one of their types of treatment, and that's all because there is not enough studies on patient and the outcome later on about the steam ablation. This is the simple device of steam ablation. It is just a device that creates a temperature in this chamber using a distal water. The temperature might reach to 200 to 300 degrees centigrade coming out of this catheter, and this is a thermal technique, and we can use also tomical anesthesia with it. It should be. The glue therapy it is the same principle, but it is costly. For one limb, it costs $2,000. If the patient have two limb disease, you have to multiply it by 2. This is just begun. It is cause, there is a lot of talk about it because it can cause myogenic granuloma, and there is a permanent implant. All the patient's life, he will feel something foreign sensation in the veins. And it can be done. What is the advantage of this? It is non-thermal. As the sclerotherapy, it is another way of treating varicose vein, which is a non-thermal technique, relatively cheap and effective. Large, can be used for large, small veins and telangiectasia, and it can be used in a foam or liquid. The foam, usually we use 7.4, either room air, or it comes in a sterile air with 1.6 of the ethoxycyclirol and mix it with the sarin ether using 3-way bath. The benefit of the foam over the liquid is that we create from 1.6 millimeter of the sclerotherapy dose a 10 millimeter null volume. So we will increase the effectiveness. So we will cover more vein using this method, using less concentration, because usually we weight the patient and calculate the dose according to his weight. So this is beneficial, especially in large veins. And foam can last inside the vein due to it has a certain surface tension that prevent blood to come between it. And for your information, blood, when it touches the sclerotherapy, it will deactivate it. So foam therapy is the best. Now I will talk shortly about the anatomy of deep veins. In the lower leg, there are 3 pairs of deep venous system exist. The anterior tibial vein, the draining the dorsum of the foot, and the posterior tibial vein draining the medial aspect of the foot, the peroneal nerve draining the lateral aspect of the foot. Just Below the knee, the deep veins join to become one single vein, which is the popliteal vein. In proximal to the thigh, femoral vein and deep femoral vein join together and will form the common femoral vein, which passes through and forms the iliac vein. This is the picture that usually we face in patients with deep venous thrombosis. We can notice that there is increase in the diameter and the circumference of the right leg in comparison to the left, and also the skin looks more shiny, and if the picture is clear, some redness. So we can talk about silent symptoms of deep venous thrombosis. Usually the patient comes with heaviness and swelling of the leg, and sometimes the patient explains either pain or tenderness, and the patient also has skin discoloration and sometimes ulcers. And the patient will feel a warm sensation, heat sensation. If this thrombus pass up and causing pulmonary embolism, usually the patient comes with shortness of breath and coughing and sudden sharp chest pain. In general, if we are dealing with a patient with deep venous thrombosis, we will prioritize the patient on a clinical probability and doing sonography, Doppler study. If it is abnormal, as I mentioned, if there is a sign of sonographic evidence of DVT, we will start anticoagulant therapy immediately. If no, there is no radiological or sonographic evidence of DVT, so this patient will go to assessment. If it is high risk, we will perform another ultrasound examination after 7 days. If no, we will rule out DVT, so there is no DVT. And at the same, after 7 days, if there is any features of DVT, we will start anticoagulant. If not, we will rule out DVT. This is the sonographic evidence of DVT. Here is the artery and is the thrombus inside the vein. A lot of doctors and patients ask us about how long we will start and finish the treatment of DVT. Really, there is no fixed time for a patient, but usually we start in acute DVT treatment for 3 months. And some patients need more time, and some patients need to change the treatment or have to go to other modality of treatment. In general, low risk of a future clot or high risk of a bleeding, if the patient with low risk of thrombosis and high risk of bleeding, so the treatment length should be short, often for 3 months. But if the patient with high risk for future clots and low risk for bleeding, so the treatment should be continued for longer time and even for life. Regarding the management principles of DVT, the goal of pharmacological therapy of DVT are to reduce the morbidity, prevent post-thrombotic syndrome, and to prevent pulmonary embolism. Anticoagulant, mainstay of the therapy, heparins, warfarin, factor 10A inhibitors, and various emerging anticoagulant can be used. This is what we have. We have some drugs that prevent the complication, but we are not sure. And we have certain drugs, what is available as a medical therapy. But in the world, there is another forms of therapy for deep venous thrombosis. Now it is not now, for years, they are using pharmacological thrombolysis, and they are using endovascular and surgical interventions for deep venous thrombosis. After all of that, most of our patients will need physical measurements like elastic compression stockings and ambulations. And thank you.
دكتور عمر عفوا اكو رول للسيرجري هسه بالفاريكوز فين سكندري تو ديب فينس ثرومبوسيس.
Yes. Previously, when we have a patient with varicose vein and we think that because it's secondary due to DVT, there was talk about absolute contraindication for intervention. But nowadays, the patient will undergo certain investigation. It is a physiological assessment of the patient using Doppler ultrasound. If the patient with good inflow, I mean good drainage from the deep system, from the deep femoral vein, if there is good inflow, this patient can be candidate for any varicose vein surgery or intervention. What I mean, because we are talking about DVT. DVT can be classified proximal or distal. If it is distal, I mean popliteal and more distal, anterior or whatever, posterior tibial vein, to the level of popliteal vein, this is 100% guarantee that there is no contraindication or relative contraindication for intervention for varicose vein. But the patient with a proximal disease with impairment that jeopardize the inflow of the femoral vein from the deep femoral system, this will be contraindicated. So not all the patients. And by the way, those patients with post-thrombotic syndrome that jeopardize the inflow of the deep femoral system will need not only intervention to do deep venous thrombosis procedures or varicose vein surgery or interventions procedure, because most of the time there is a more proximal disease, including the iliacs and even the IBC. So there is no absolute contraindication, and it should be more specific, and there are certain precautions to be done with each patient, selected patient. When I choose a patient with history of DVT, and now the veins, his deep veins are recanalized, and I decide to do sclerotherapy, for example, or laser for him, I try to use, some people say 1 day or 3 days of anticoagulant subcutaneously to avoid a recurrence of the DVT as a prophylaxis. Any question?
وهي هذه عفوا بالليزر cannot be recanalized again.
Laser, the mechanism of laser or whatever the thermal technique, it is used to generate a high temperature inside the vein that makes protein denaturation of the endothelium. After that, it will, after compression, because usually after the procedure we put the patient in a stocking or bandaging of the patient. So this trauma and compression will cause healing, fibrosis. It is not about reopening the trabeculae or whatever. But nowadays, maybe within the coming 1 or 2 weeks, we will start such a procedure in Iraq for the first time in Kerbala, in Zain al-Abidin Hospital, with help of another team from other city, with Dr. Haidar Safar, that we will start first treatment for simple deep venous problem, including the mitral syndrome and some cases of post-thrombotic syndrome, in form of recanalization and stent insertion. So maybe within the coming 2 weeks, we will face the first venous stent that is inserted in Iraq soon.
الستنت يعني الاكشن نفس الفالف مع الفين. انت بتقول لي ستنت يعني انا خلي ستنت بالارتري.
نعم.
انا هسه الفين اذا خليت له ستنت شنو يعني راح استفاد؟
I didn't go in details about the pathophysiology of chronic venous disease, but mainly it goes with either reflux or obstruction. We are using stent to overcome stenosis.
Not the reflux.
Not the reflux.
No.
There are certain surgeries of deep system that can be used. We create a new valve, either creating a new valve from the trabeculae inside the vein, or we are going to transfer another vein from a healthy area to this area. And this is all about the deep femoral vein, because this is the cornerstone for treating the inflow of the deep system. Sometimes they create a fistula in order to increase the inflow. But by the way, when the fistula closes by itself or by a surgery, all the post-thrombotic events will regress. So still, we are talking about a stent, but in some centers in Europe, they are using the creation of new valve or transposition of the valve. And even now there is a studies about certain types of stents that that has its own valve. So valve stent.
عندك مشاكل هواية.
Yes.
هو يعني هذا كان
It will
سؤال.
prevent.
انت الستنت تخليها الستنت بالفين فالف المفروض.
Yes.
يعني يطلع البلاد اب بس نفس الاكشن اوف ذا فالف نفس الفين فالف.
Usually the mechanism of the chronic venous is either it is reflux or obstruction. Ready to find it is both. In obstructive vein you cannot find a reflux. And a reflux vein usually because the flow is a bi-directional you cannot find thrombosis. حاضرين.
البين تناسب ذاك الباص ياخذها يقطع كذا يعني.
ياخذونها أي مكان. شكرا جزيلا.